Hello, everybody. My name is Mike McKee. I'm a professor here at the Department of Family Medicine here at Michigan Medicine and also University of Michigan Medical School. So we are delighted to have our next MDisability Provider webinar series. And we are very fortunate to have three doctors join us. So Dr. Sherry Day, Dr. Heidi Joshi, and Dr. Tyler James. And so this topic will be centered on how we can better care for people who identify as being blind or have low vision. And this is part of our MDisability Provider webinar series. We do want to acknowledge our funding. We have funding from our department chair to support these efforts. So we're very fortunate and appreciate their support. Also, just to let everybody know about how we are having this set up for accessibility. We do have a captionist available. So if you are curious and getting that set up, if you look on the bottom of the screen, you'll see CC and you can just select that to activate it. And then I want to also now move forward to, first of all, acknowledge Liz and Dawn Michael for helping set this up. And this is a continuation of our series, so we're very fortunate to have their help. The second, I want to go ahead and give a brief introductions of our three panelists. So I'm going to start with the first one, Dr. Sherry Day. Dr. Day is a clinical assistant professor at the Kellogg Eye Center, and she is leading efforts in vision care, contact lens, and low vision rehabilitation, and has over 20 years at University of Michigan. She specializes in low vision rehab and has partnered on a lot of different research to really just help with vision enhancing solutions and really just very dedicated in helping with a lot of the care, addressing the needs for people with low vision and who also identify as being blind. Dr. Heidi Joshi is a clinical psychologist and assistant professor here at the Department of Family Medicine, and she specializes in integrative behavioral health and provides therapy at University of Michigan and our family medicine clinics. And also, she is an assistant residency director and really specializes in a lot of care around depression, anxiety, ADHD, and other behavioral health needs in primary care. And then Dr. Tyler James is assistant professor here in family medicine and also has a lot of research around healthcare access for people with sensory and developmental disabilities. It also has a lot of expertise around caring for people for deaf-blind and research best practices, and also works closely with collaborators on CHARGE syndrome. And he's an accomplished research methodologist and does a lot of teaching around social epidemiology and mixed methods, and also provides a lot of editing for a lot of leading journals around this area. So I'm delighted to turn it over to, I believe Dr. Sherry Day will kick us off. Thank you.
Hi, everyone, and thank you, Mike and Dawn and Liz, for having all of us here. So today's webinar is really about the primary care providers. I know that I've gotten questions over the years from my colleagues, what about patients with blind or low vision, and how do I refer? And so today I have the clinical experience over 20 years at the Kellogg Eye Center, but Dr. Joshi has a lived experience. And so we hope to have a nice dialogue between the two of us, and please feel free to enter your questions in the chat box, and we'll be monitoring that as well. So why does this matter, right? Why do we need to do this? Well, it matters because we have so many people around the world. I mean, just, on the WHO website, you'll see that there's 2.2 billion people around the world with either blindness or vision impairment, and in the US as well. And there's, of course, lost productivity with that if people aren't able to continue in school or continue to work. Vision loss is associated with high risk of falls as well, stress and anxiety, and that's part of our research. Actually, we have an NIH-funded research on that. Medical errors, employment disparity. And primary care providers play such a crucial role in identifying these patients, and early referral is really crucial for these patients to continue to function and live a very productive and meaningful life. So, and that is the goal in low vision rehabilitation, to remain as independent as possible. The next slide is about communication etiquette, and Dr. Joshi, would you like
Great.
to take the lead on that?
Sure. So I'm going to talk a little bit about some tips and tricks for communication with folks who are blind and low vision. And so these really come from lots of different places, but also the lived experiences of folks who are blind or low vision. And so I'll go through some of these from my own perspective, but also from the perspectives of others as well. The first one I put on here is, make sure that when you're coming in a room or leaving a room to let somebody know. And that can be a little bit counterintuitive, but if folks are not seeing whether you're coming or going, it's just important that people aren't talking to you and you're not there, or, something like that. It's good to make sure that folks know who's in the room at all times. And so introduce yourself too as you come in. Sometimes it's hard to know who's in a room, and so making sure folks are really aware of who's in their space can be very important, especially in a healthcare environment where we want to make sure that patients are consenting throughout the whole process. And part of that consent process is knowing who's in their room at all times. So if a physician walks in the room, to be able to say, hi Heidi, it's Dr. So and so. I'm here, or I'm going to step out for a minute. Things like that. So we want to be as verbally communicative as possible. There may be patients that don't need that or don't want that, and they'll let you know if it's too much. Using language that patients are comfortable with. There's a lot of discrepancy in the literature about whether we should use what's called person first language or not. Personally, I like person first language, meaning I'm somebody with a disability as opposed to a disabled person, but that isn't the case for everybody. And given the fact that folks are in lots of different stages of their identity as a person who is blind or low vision, they may prefer a different way of speaking. It's not incumbent on you to know that, but feel free to ask what their preferences are. So I think goes without saying for anybody, but especially for a patient maybe who is blind or low vision, explaining what you're going to do before you do it can be very important, especially if you're in an exam situation or a procedure, to let folks know what's going to happen, or as you're doing it, right? I think a lot of physicians know this with their patients in general. It's good to talk through what's going to happen as you're doing things, especially before you touch someone. They're not going to see you coming necessarily. And so it can be very helpful to say, hey, I'm going to touch your arm, or I'm going to put my hand here, or you're going to feel a little of this, just to be really mindful of that. Next slide. Oh, I do want to just mention before we move on to address patients directly. So it can be very tempting to talk to um, if they have a companion with them or a caregiver in the room, it can be tempting to speak with them and not the patient directly. So please talk to patients directly, and if they need you to not do that, they will let you know.
Dr. Joshi, if I can jump in
Yes,
and
please.
ask you a quick question. So you mentioned
Yeah.
touching. Patients who are blind and low vision can, of course, be aided with touch. And I see that you're about to potentially discuss guiding, which is a form of touch cues. That proprioceptive feedback can be very important, especially, for instance, like letting a person know that you're in the room. So co-presence, vaccinations, like letting them know where you're going to be delivering the vaccine. What are your thoughts with providers and staff providing consensual touch in the clinical environment? So like, for instance, during a one-on-one discussion, perhaps like touching a person's forearm to let them know that they're there. How would you navigate that situation?
So I think it's really the patient's in charge of that situation, and I'm not a touchy person, and so I'm somebody that tends to shy away from unnecessary touching. And at the same time, when I train physicians, asking if they can touch you in order to examine you is also, I always say, like, don't ask a question that you actually can't afford the answer to. And so if you need to touch a patient to examine them, it's better to say, I'm gonna, touch your arm or touch your shoulder, or I'm gonna take a listen to you, and you'll feel the cold stethoscope or whatever, as in that situation. But I think if there's touching that's unnecessary and it's just to say, hi, I'm here, I would err on the side of not doing that personally unless a patient gives you permission.
Great,
That's
thank
just
you.
my take on it. Yeah. So let's talk a little bit about guiding. Tyler, do you want to talk a little bit about this? I know this is kind of one of your areas of expertise and research.
Yeah, thank you. So guiding in the clinical environment. So this is something that we have worked very hard on and with partnership at Office of Patient Experience here at Michigan Medicine. It's important to recognize that there are ways and methods to navigate with a patient who is blind or low vision safely and efficiently through a clinical environment through sighted guide or human guide technique. Many patients who are blind and low vision go through training called orientation and mobility training. And this teaches them how to orient to their environment and navigate safely, independently, or in co-presence. We have developed a human guide training that's available for faculty, staff, clinicians, and volunteers at Michigan Medicine. I think that one of our staff members will be able to put that link in the chat. But whenever you're working with these patients in this type of environment where you're guiding, it's important that you don't push or pull. It's important that you provide consent, explain that what you're doing, or wait for them to ask you to guide them. And also, many times individuals will be working with a service dog or using a white cane or other mobility tool. Those tools are still there for them to use. And so don't feel like just because they have those tools, they don't necessarily need assistance, or that if they're using that tool, that they don't, yeah, if they're using that tool, they don't need your assistance. So really like err on asking the patient or visitor what is most comfortable for them and what they are needing to navigate your environment.
Thanks, Tyler. I think that's really important. The other thing to remember, especially if a patient doesn't have much vision at all, is you can sort of tap the back of a patient's hand with the back of your hand so they know where your arm actually is in order to take your elbow, as opposed to just trying to search around for somebody. That can be a little awkward. So that's another way to just initiate that guiding situation, especially for folks that maybe have little to no vision. I thought maybe I'd say a little bit about the service dog etiquette while we're on this slide. I think folks in general understand that service dogs are there to do a job, but it can be very tempting to pet or talk to a service dog, and it's very important since they are working that, that the dogs not be interrupted with their job. So even if they're not guiding the person in that moment, maybe they're laying next to them on the exam room floor, they're still considered working and still need to be able to attend to what's going on. There are other things that are important to know about guide dogs. It's important not to make eye contact, especially with a guide dog, because the person who is blind or low vision isn't necessarily able to make that eye contact, and dogs are very visually based. And so you wouldn't want to give a dog more information or more input than their handlers. And so we always recommend to not make eye contact with the dogs while they're working. The best way to know a guide dog is working is you'll see a handle or a vest, and this is true of any service dog, they usually have some indicator, but by law, they don't have to. So I use a guide dog, and if I walk into a building and he, for some reason, doesn't have his harness on in that moment, he may still be serving a purpose. And so by law, he doesn't have to have that harness for me to say that he is a service dog. We won't get into the pros and cons of that. That's a whole nother lecture, but it does have some sticking points for sure. Do we want to move on, Sherry, to the next one?
So this slide is about access to information.
So shall I jump in here, and then if you two
Yes.
have questions or okay. One of the things that comes up in physician offices is access to printed information, especially with forms that need to be filled out. I think this can be very stressful for patients who are blind or have low vision. And so I would say if you have a patient in this situation, if you can make sure they know they can ask for assistance. One of the things I tend to have to do is let folks know before I come in that I may need assistance with paperwork, especially that initial paperwork that can take a fair bit of time. And so I may have to come early for the appointment and make sure that there's staff available to give me assistance. But don't assume that the person with them is who they would necessarily want giving them assistance with that paperwork. You know, usually it's fairly sensitive information, and so, you know, people need to have control over who works with them on that information. Sherry, can you talk a little bit about large print and how that is done and what your thoughts are around that?
Sure. So large print means, you know, you can magnify it. I guess our standard usually is like a Times Roman 12-point font, right? So it depends on the vision, and it's hard to say, should we magnify that 5 times or 10 times for the patient? However, you know, if we just make an effort to enlarge it, but I think nowadays our patients are using the tablets. And if the tablets have the accessibility functions, it'd be great if we folded it and enlarge it as much as possible. And same thing with our websites. I think that sometimes you could change to the larger text on the website, so it'll be a lot easier to access for the patients. And if they're audible, it'd be even better. In terms of being in the clinic, I also ask our staff members to ask the patients, would you prefer that we read this to you, read these questions to you, and sit and answer with you? So I think asking the patient how they would like to fill out the forms is always the best.
Note about Braille and large print is I think there's a bit of a misconception that if you're blind, you automatically read Braille. And I believe, and Tyler, you may know the percentage of this better than I do, but I believe it's around 10% of people who are blind or low vision actually read Braille,
That's correct.
which is not a very high number. And so, you know, for whatever it's worth, I think that's just something to keep in mind, that just because someone is blind or has low vision doesn't mean that they necessarily read Braille or use large print or even understand how to utilize the assistive technology that's available. And so we just want to always ask before we make assumptions. Tyler, do you have any other thoughts in this regard?
Yeah, just one thing I wanted to mention is that many instances of Epic, the leading electronic health record system, do have after visit summaries that have large print settings. So for instance, Michigan Medicine, if you go to the after visit summary page, there's a drop-down menu where you could actually request it in a large print. I believe it's actually size 16 to 18 font. It's not necessarily fully customizable, but it is more than the tinier font that is normally on an AVS. So that's just something else to keep in mind.
And also the MyChart or Epic patient-facing versions are usually fairly accessible for folks who do use assistive technology. And so accessing information via those after visit summaries or appointments and things like that is usually pretty streamlined if you have a patient that is very, you know, comfortable with those technologies. I think we can move on. I'm going to talk really briefly about managing medications. I think one of the things that can come up for folks is when prescribing medications is making sure that they're accessible. And so there are a few things to consider. I think for a lot of our primary care folks, you know, diabetic medications is one of the areas where we might see a correlation between low vision or blindness and the use of medication. So remember, there are talking glucometers out there. Some are better than others. I am not an expert on the better ones, but know that there is some variation in those. And making sure that whatever you're prescribing is accessible to a patient. So if somebody is newly blind or newly has lost some vision, things like measuring liquids can be tricky. Using syringes and that kind of thing can be tough. So when it comes to insulin pens, for example, sometimes the pre-measured ones can be much easier than the ones that you have to dial up. And even if there are clicks, I've heard from folks that those can still be tricky and you still can't be guaranteed that you're getting the right amount. There's no feedback mechanism for that. As far as reading labels on medications, there is a wonderful thing called Script Talk, which is a talking label that you can get from some pharmacies, but not all. I believe CVS has them. I think Walgreens might have them, and I'm not sure which other pharmacies have access to Script Talk, but it is something to know about. And so the pharmacist would be the one to basically provide the label that gets put on a medication bottle, and then there's an app on an iPhone or an Android that will read the label, so folks know what the medicine is and what the dose is and everything. Sherry or Tyler, do you have any thoughts about this medications and what you've heard works, doesn't work?
Yeah, some of our patients, once they go through our low vision clinic, some of our patients will also have vision enhancing tools, devices that can aid in seeing, the medications that they're taking. So those are things that we could talk about in just a bit. We also have occupational therapy who can do home visits too, just to make sure everything is working out well.
And I'm a huge believer in doing what works. And so if somebody, let's say, is not a braille reader and they don't have much vision, maybe they just want to stick a rubber band on a bottle so they know which one is which. And so sometimes there's just low tech ways of delineating one thing from another.
Absolutely.
Yeah, this is Tyler speaking. Just to add in, this is an area that is under continuous development right now. So the National Foundation for the Blind has been advocating for a Medical Device Accessibility Act for the past several years. Continuous glucose monitors and insulin pumps still face accessibility challenges for people who are blind and low vision, and there's actually accessibility task force group dedicated to continuous glucose monitors. Again, finding out those low tech ways are probably most helpful for patients. I'm really glad that you mentioned that, Heidi, about the rubber band.
Huge fan of low tech. Yes. The other thing to think about, I was thinking about this recently with oral contraception is another great example that we see folks struggle in terms of the way the pills are set up. Sometimes they're in a circle, and sometimes you'll get rows of pills, and the circle ones, folks can't tell where the circle ends and where it begins in a new pack, for example. And so those can be also tricky. And so sometimes it's nice to just think through with a patient what's going to work best for them if they're doing their medications on their own tactily. Next slide. Sherry, do you want to go through these little pearls?
Yeah, so
Review.
clinical pearls of do's and don'ts. We've kind of been covering this a bit, but in general, just like Heidi was saying, we want to narrate as much as possible if the patient wants what we are doing, so patients are not surprised. There are some patients with peripheral vision loss, for example, and so I'll even just be bringing a lens to them, and they're just surprised because I haven't announced it. I'm not used to doing that. So talking through what you're doing is important. And tripping hazards. So in the patient's home, typically they're doing fine. When they come out of their home, things that move, there's backpacks on the floor, like if they're in the airport, or even in our lobbies, right? If there's anything on the floor, we want to make sure that the pathway that they're taking is free of tripping hazards. And just in general, we've talked about the theme of asking the patient how we can best support them. And don't assume that everybody has any tools or they know how to read Braille. Don't assume that they all want to be read to either. So asking the patients. So we went over a few of these, do's and don'ts about service animals as well. Anything
And I
else
think,
to add?
yeah, I think just really remembering that just because a patient struggles to get around the clinical environment doesn't mean they're going to struggle to get around their home or other, unfamiliar environments present challenges for folks that have low vision or who can't see on a good day. And so orienting any unfamiliar environment, folks often will need assistance or ask for assistance. And so I would say be careful to judge a person's ability based on what you see in an unfamiliar environment.
If I can
Tyler,
ask
yeah.
both of you on your experience with this. So for instance, in social settings, some blind and low vision friends or deafblind friends prefer to take their phones and use a magnifying app, right, to read the menu. If a person is doing that in a clinic, a patient doing that in the clinic, of course, like this could lead to additional time that's necessary to take with these patients. how do you recommend providers or clinical staff facilitate that extra time with patients who are blind and low vision?
I think I would think of it more as what we do when we have maybe patients that utilize interpreters. I think, we can make notes and maybe take a
Mm-hmm.
little bit extra time or put something in the chart that allows us to say this is somebody that may need a few extra minutes so that it's not a surprise, just like we would for other situations that come up in clinic.
Mm-hmm.
And I think in my chart, in the left column, we can put in the accessibility requests of any sort, like wheelchair or wheelchair accessible room, or if they read large print. So I think it's important for us to kind of enter that and for providers to be aware, to be looking at that.
And that's for Michigan Medicine. Having used Epic outside of Michigan Medicine, that tool is not always available. So sometimes putting in just like an FYI to yourself or a sticky note or something that just helps you to know what's coming up and that this is somebody that may need some different type of assistance can be very useful.
Thank you.
Okay, next slide.
Yep.
Referrals. And this is talking about, and I'll take the lead on this, referrals. How do we, I get a lot of questions like, how do we refer? Who do we refer? How, when do we refer these patients, right? So the first thing I would recommend is perhaps having some literature or training your staff that the service is available for patients with any sort of vision functional difficulties. And I say that it's vision functional difficulties because they don't have to have vision impairment. They don't have to have blindness or low vision, but some sort of, they might have had a stroke, for example, right? And they're having functional difficulties. And so we'll see patients at that stage as well. So asking the patient, are you having difficulty cooking, or you have just their daily activities? ADL means activities of daily living. So if your staff is aware of that, you're aware of this service that's near you or in your hospital, it's a very important first step. Sometimes because of the difficulty, they're not able to function in their daily activities as they normally would. Now they have their stress, they have anxieties around being dependent on somebody else, or they can't drive, or they can't do certain things. So those are, we can ask about that, and we can refer for that as well. So how do you refer? Primarily, you want to know the eye doctor that's near you. So optometrist, ophthalmologist. The first thing I would need as a low vision provider is a comprehensive eye exam. We want to know what the diagnosis is and where the issues are, so that it helps me as a low vision doctor to understand how to examine the patient, how to customize our time together to reach the patient's functional goals. Patients who are veterans of the military service have the services at the Veterans Hospital. Not all hospitals, not all VAs offer the service, but for example, in Michigan, the largest comprehensive center is in Chicago. However, Kalamazoo has a scaled down version of low vision services. And also, if you can include a note to the eye doctor and say, hey, I noticed, I've talked to the patient, they're having these issues, X, Y, and Z, they can't do this during the day, they're having difficulty at work. Having a note, providing a note, it would be really helpful for us to get started. And how do you prepare the patient for the eye exam or the low vision service? And those are discussions that I have a slide on that too, of what the low vision exam entails, what the low vision time entails, and the team players that are there to help them. So we can discuss that in just a bit. Anything else that you guys want to ask or discuss?
I was just going to mention that there's several community organizations that can also help, not necessarily for clinical referral, but for some of the orientation and mobility, independent living skills training, and also just access to resources. So like Michigan Braille and Talking Book Library, for instance, every state has a Braille and Talking Book Library or a library for the blind and print disabled, which can help with getting information resources. Leader Dogs for the Blind, based out of Rochester, Michigan, is also a really good partner. They do their guide dog services are completely free of charge to the consumer. They also provide free orientation and mobility trainings to eligible consumers. And so that's something else to keep in mind.
Yep. And we have a slide on all those other resources too as well.
Oh,
So,
perfect. Sorry.
yeah,
Jump the gun.
perfect. No, that's perfect segue into that. Okay, so I talked about the VA blind rehabilitation centers. The comprehensive ones, and I only listed 2 as an example, but in central in the central states, it's in Hines, it's at the Hines VA in Illinois. And the multidisciplinary team is what is entailed in these comprehensive centers. So the low vision team includes the ophthalmologist or optometrist, and the optometrist is the low vision provider, PMNR, social work, there's recreational therapy, psychologists, and caregiver training as well in these comprehensive centers. Hines V also has 34 beds, so it's an in-house kind of rehab center. So, and also a western part of the US is the Palo Alto VA, very popular, very famous for that. In a lot of these VAs, Ann Arbor VA has the VIST coordinators, Vision Impairment Services team. So they will coordinate the services for the veterans. So if they need, for example, if our patients need to go to Hines VA for the comprehensive training, they will coordinate all that. Or if they need any devices that I've prescribed for them, then these VIST coordinators, I'll write a letter to the VIST coordinator of these devices or rehab services, and the VIST coordinator will get these devices or services to the veteran. So what to expect at the low vision clinic? Well, so the first thing is after the comprehensive eye exam, now we have a diagnosis. Now we know what the issue is. For example, we need to know if it's a central vision loss, or is it a peripheral vision loss, or is it just scattered vision, or is it a stroke, or is it a tumor resection issue? So now I know kind of what the vision loss is. When the patients first come in, we go through a very comprehensive questionnaire to establish the patient's vision and function goals. So for example, somebody comes in who's a musician, right? So those questions will be tailored towards them. Are you having difficulty reading your music? Are you a conductor? How far is your music from your instrument, et cetera? So versus someone who is a computer, IT person, right? They're on the computer all day. So their working distance is different. Their needs are different. So the comprehensive questionnaire kind of goes through all aspects of their life, their cooking, their schooling, their recreation, and their occupation, visual needs. So then once I know that, then we get started with the low vision exam. So it is a thorough checking of the vision, and not so much the dilation part or the ocular health part, because we already established that with a referral, but it's more, what is the best corrective vision this patient has? And then I move on to what is their need. I have to test their near vision to see how I can achieve their reading goals if they have one, their distance or their intermediate distance goals. And I'll do other testing pertaining to their goals. One of the primary goals that my patients have is I want to continue to drive, right? In the US, we're very dependent on driving. We don't have great, high-speed trains or anything like that. So the patients need to drive. And without driving, they've lost their independence. So patients who want to continue driving, I'll do other testing, such as visual field testing, out to 130 degrees to establish whether they can drive. And we'll have discussions about that. So once I've done the thorough exam, now I know what kind of devices, and I'm testing them I know what powers they need to achieve their goals that they've told me about. And so then we'll go into the testing of different magnifiers. I know what powers they need, the telescope, and telescopes come in a variety. I mean, we can do autofocus, we could do manual focus, we can mount it in glasses, they can hold it in their hands. There's so many different ways to do telescopes nowadays. And of course, a lot of the electronics nowadays, even for tablets, they look like tablets, but they're magnifiers, electronic magnifiers. They're head-mounted devices. They're devices where it looks like the meta glasses, for example, and can read to them. So there's a lot of advancements in vision enhancing devices nowadays. And referrals. At this point, I will say, let me fit you with these devices. This is what's going to achieve your vision goals. Now, you also need to be referred to, say, orientation mobility specialists, or they have a lot of anxiety and they're very angry about the vision loss. We have psychotherapy on board. We have support groups for them and their families. There are a lot of state and federal resources, and Tyler talked about the local support groups, or the Library for the Blind. So that at that point, we will fill out the paperwork for them to refer them, depending on what they want to do. Some people don't want to read. They don't want to listen to books, and that's okay. And so we also have occupational therapists on board, and she actually makes home visits, currently within 30 miles of Ann Arbor. And so she can go into the homes and see, hey, is there a way we can mark the stove, so in markings or adaptive markings for that, to see if it's easier for them to turn off the stove, make sure it's off. So testing in the clinic is of course different than in the patient's homes. Lighting is different, right? They're set up, there might be a lot of clutter in the homes, and so she'll make recommendations there. And if she can't get to them, if they are legally blind, we can also go through state resources, and I'll have a slide on those resources too. So this is what they can expect, the patients can expect at the low vision clinic. We mentioned some of the resources. The patients or the families can go on the websites and learn about these. American Foundation for the Blind, they have a lot of webinars as well. Foundation Fighting Blindness, we've done webinars for them. Vision Aware, ADA, Script Talk, we mentioned that. The National Library Service is where we can also fill out the paperwork for the Library for the Blind, where they can actually get digital books mailed to them, and that's all free service. And Hadley is just an example, but Hadley is it's an organization out of Chicago that has a lot of podcasts, but also you can learn Braille through them too. Heidi and Tyler, do you want to talk about these other resources?
They have other courses you can take too besides Braille, which is, even if you want to learn a hobby, or, they're home-based courses that Hadley offers. There's a whole catalog of them.
Yep.
And then
nice.
similarly, if I can add, the National Center on Deaf Blindness, which serves families with children who are deafblind from ages 0 to 21, have several webinars and self-paced modules focused on early literacy and developing fund of information for those populations.
And we've spoken a lot about adults, but remember, for kiddos, there's the school district can be a really important resource to keep in mind for making sure that kids have accommodations in school settings as well.
Yes, and I don't know if I have a slide on that, but that's one thing I did want to bring up with the individual education plan. I do see children in our clinic, and once we know what devices they're going to need in school and what devices they need at home, I write a summary letter for the schools and to include in their IEP. And we also work, for example, Ann Arbor has a really good system we have a lot of teacher consultants for the visually impaired, so they'll work with the children, look at the devices they need. It's important to realize that not all districts have that service, but it's our, we do write those letters for our pediatric population. Anything else to add?
I was just going to add on. So for instance, you mentioned not all districts have those services. So for instance, Ohio uses itinerant consultant teachers of the vision impaired who consult for individual school districts and work with students that way. But the school districts are required also to provide a lot of services for these students who are eligible for an IEP or 504 plan, including a functional vision assessment, which does very similar assessments to the rehab side of medicine.
Yes. And we'll get referrals from the school districts too. If the teacher consultants or the teachers actually picking up, some vision issues with the children, so we'll get those referrals too. Okay, I'm going to move on to the next slide. Service coverage. So this is just an overview of some of the state services that we've been kind of talking about. So Bureau of Services for Blind Persons is just about throughout every single state has that department. It might be kind of labeled differently, but this is where patients with legal blindness has these free services provided by the state. There are vocational rehab agencies in most states as well, especially for patients who are continuing to work, but they're not necessarily in Michigan, not necessarily legally blind, but they have vision impairment. They want to continue working, so they'll have other resources for them. Youth services. So the Youth Low Vision Service is under the Bureau of Services for Blind Persons in the state of Michigan. And those, and for example, ours has college preparation training summertime for the kids who are going to go to college in the next 1 or 2 years. And so they'll go to a college campus and actually stay there for a few weeks and kind of learn the skills to navigate a college campus, and also use devices that's needed. And we talked about the school districts and insurance. So we can always insurance is always kind of an issue for the low vision device coverage. Medicare does not pay for low vision devices. However, Medicaid per state will cover some of those. So for example, Michigan in general will cover the basic handheld magnifiers or basic telescopes. But if it's a eyeglass mounted telescope or anything more special than that, it's a case by case basis. Anything else to add about that? Okay,
I was just going to say that I think it can vary with other types of assistive technology devices as well. For folks who have no vision, having screen readers or access to electronic braille and things like that is a fairly expensive proposition. And so depending on whether a patient is working and their employer covers those technologies versus, whether they're at home and a state agency may have to assist with those technologies, but there are multiple ways around the expense of that equipment, but it can be a pretty big barrier for people.
Mhm. Yes, I fully agree with you. It's one of the devices for patients with little to no vision is called the OrCam, which has facial recognition. It can read anything to you. It has obstacle detection. However, that runs, for example, about $3,000 to $4,000, right? And so it could be a financial barrier for many people that need it.
If I may add, there is another program that is for individuals who are dual sensory impaired, so deaf and blind. This is the I Can Connect program or National Equipment Distribution Program for individuals who are deaf blind, and they can provide assistance with getting braille readers, screen reading technology, computers, iPads, and cellular devices.
Oh, and I didn't mention, there are certain phone apps for patients with vision impairment that can be very helpful depending on their vision. So this is where our certified vision rehab teacher comes in, as well as our occupational therapist. They can introduce our patients to these apps that can be helpful. And some of the apps have a live agent on the other side to help
So
navigate.
some of them can help with things like reading money. Like I have an app on my phone that will tell me, whether I have a 1 or a 5 or a 10, because I think, some countries have Braille on their money, but not ours. It all feels the same. And also I have other optical character recognition apps that can read, menus or what's on a screen. But like Tyler was saying, that can take a minute, right, to be able to access that information. There are some apps that are color identifiers. There are apps that will have some facial recognition now, which is kind of hit or miss. I haven't, I'm a little leery of it still, but so there are definitely apps out there that can make life a lot easier. I would say my iPhone is the most highly used piece of accessibility tool that I have in my home because of all the apps that it can do.
Okay, so those are all the slides we have. I'm going to stop share so we could take any questions, comments.
Thank you so much. This is Mike returning. So first of all, thank you everybody for sharing your rich feedback and your insights on this. I know this can be an area where many primary care providers, family medicine physicians, and other clinicians who just simply don't get training. So this is really very helpful for us. Um, well, I also just want to let all the attendees know, if you have questions to put it in the Q&A and we'll address them as they come up. While we're waiting for the questions, I do want to maybe go ahead, sorry, and pitch this question. Given the costs, obviously with myself having hearing loss, I use different assistive devices, and that's not very different if you talk about those who might be blind or have low vision. In terms of the devices, sometimes it can be a little intimidating to take the plunge and pay $3,000 or $4,000 for a device. Is there an opportunity or like a closet, like a technology closet where people can experiment and try them before they make a commitment? Are you aware of any opportunities around that?
What I'm aware of is sometimes the public libraries will have some of this. I think downtown library, last I checked, they had some devices there to try, like especially the CCTVs with the reader with the camera. So, and I don't know if you could check it out. You might be able to, but you could definitely use it there.
There are some technology conferences that exist for specifically for assistive technology. And so if it's not prohibitive, sometimes it can be fun to check out different. I use what's called a Braille display, for example, and that's hooked up to my computer and it basically shows me in Braille what's on my screen, along with it talking to me. If I don't want the screen, my computer talking, I can turn that off and just read the Braille. But I'm really picky about what kind of Braille display I use because I am just like we all get to be picky about certain technology. And so I've had to try out many displays, and so that's one way that you can do that. Sometimes there can be used pieces of equipment that people will sell for much cheaper. There's just like on Facebook or Craigslist, there can be websites that will sell used technology as well. Tyler, are you aware of any other resources?
I was just thinking that a lot of lighthouses for the blind also have some of these equipment libraries. I don't know that you can check them out, but they certainly have like computer labs, for instance, where you can access some of these magnification devices, test different screen reading technologies and things of that nature. And just to clarify, Lighthouses for the Blind are community-based organizations, nonprofits that are based in many major metropolitan areas that provide services for people who are blind and low vision.
Thank you so much. Next question. We were curious, given that we're talking to an audience of family medicine physicians and primary care clinicians, are there health things that we need to consider? So for example, any screenings that we should consider and tailor for these individuals? Are there any other best practices that we should be mindful and perhaps we didn't get training on?
So from a psychological mental health perspective, I think it's important to think about vision loss as an adjustment process, and it's a pretty monumental one. And so if you have someone for whom vision loss is maybe a part of their diabetes or some other chronic disease, or it's from a stroke, or it's, whatever the reason, I would always assess for other mental health comorbidities with vision loss, especially depression and anxiety. And I would do it fairly regularly, not too often, but enough so that you can see changes in case folks are getting worse rather than better. I think of this as a grieving process, and so it's important to be, thinking about what's going on with folks mental health wise as they're adjusting to a pretty monumental experience.
I was just going to also mention, so Heidi discussed diabetes. I think that for patients who have diabetes currently, ensuring that they are getting their vision checked can be incredibly useful. I mean, even patients that are in relatively good glycemic control can still develop retinopathy. Although the risk is significantly lower, it does happen. And for patients with type 1 diabetes, it can be very like fatalistic. Like, "Oh, this will happen. It's a matter of when, not if." And so again, as Heidi mentioned, just that psychological support management for those patients. So not necessarily even patients that already have vision loss, but those that might develop vision loss.
I think it's also important to remember that folks' ability to move around their environments really shift as vision is lost. And so access to physical fitness, exercise equipment, it is incredibly difficult, for example, to find um, the same kind of equipment that you might think of at a gym that is accessible to you who can see a screen. But now that everything's on a screen, that can be difficult for folks who lose their vision. Sometimes balance can be affected as well. And so, just remembering that folks, especially as they're adjusting to vision loss, have more of a propensity to fall. I think that can be important. And also just access to being more active. That can be really difficult and it can take some creativity.
And to talk about the mobility part, right? Once they lose their vision or they can't drive, for example, this is where I do refer patients to a social worker to explore resources in their county or wherever they are. What's the best transportation service they have there? I mean, they can always use Uber and Lyft, but of course, that's more expensive.
Thank you. And I want to let all the attendees know that there are some links being shared in the chat, and also tip sheet that was developed by many of the members here. And these are really helpful resources, just kind of like what are the nuts and bolts, just in terms of care for these individuals. Next question is really centered on prescriptions. So I know we talked about the script talk. Should clinicians type in information about that this is an individual who might need some modifications with the script, or is that something that the patient should connect with the pharmacist?
I think from a patient perspective, I personally prefer having control over that process myself but that's probably because I prefer that with a lot of things. And so I think it's nice to give patients that autonomy and maybe just educate them that these things exist, and whether they choose to use them or not is really kind of up to them and how they manage, things at home. And so um I don't think it's necessary unless patients ask for that kind of assistance. That's just my own opinion. I don't know what Tyler and Sherry think about that.
Sherry, I'll let you go first.
In terms of the prescriptions, at least in our clinic, we always offer that, right? Because I think most people don't know about it. And so when they talk about, when I see that they are diabetic or they have hypertension or and I reread their list of meds, it's like, okay, well, somebody has to manage this accurately. So we do make that known to them if they want it.
Yeah, I agree. I was going to say what Sherry said, which is I think that it's important to offer it, but not necessarily just take it upon yourself to do it. Both of my parents are deaf and hard of hearing, and for the longest time, neither of them knew about a lot of the accommodations that were available in medical or in public settings for them, like closed cart captioning, for instance, during appointments. And so I think it's important to offer it, but really follow the patient's lead.
Thank you. We have another question from an attendee. What, if anything, should a physician who is blind or low vision tell a patient about their approach to care? So be mindful that many of us who are clinicians also may have different types of disabilities, and I don't know if anybody wants to talk about that experience. Dr. Joshi, I don't know if you want to take the lead on that one.
So I think for someone like me who has no vision and also as a provider, I'm pretty out there. I walk in a room with a big German Shepherd guiding me, or a cane, and so it's pretty obvious that I cannot see. Um, but I don't really say a whole lot about it other than I'll ask a patient if they're comfortable around dogs. And And it's been my experience that 95% of the time people generally don't ask me more questions about that, and I'm really there to sort of focus on the patient. And so I personally have chosen not to make to say a whole lot about my own personal experience with vision loss. It doesn't mean patients aren't allowed to ask, but I don't necessarily open that conversation if what we're here to talk about is their depression and their anxiety and things like that. That may be different for primary care physicians because as a therapist, we have certain ways we do things that are a little bit different, and we don't focus on ourselves as a general rule in the mental health world. Um, but I would say that's generally how I manage it for myself, is I really try to keep the focus on the patient. And if a patient struggles or has a question about my vision loss or whether I'm going to be able to manage their care, I'm certainly always happy to talk about it. It hardly ever comes up. I think it comes up more in other people's minds than in actual reality for me.
Thank you so much. I think that's all the questions we have here. I know we're getting close to 1 o'clock. So I want to thank everybody, thank all of our panelists for joining and sharing their insights. It was great to have these different perspectives and just coming together, give us a little bit of guidance. Again, thank you to the team for making this happen and also for our captionist, Julia. Any last pearls you want to share or any last comments from the panelists?
It just looks like there's a chat question about which lighthouse
Mhm.
people use.
Oh, I
Tyler,
did.
do you want to take
Okay,
that
yeah.
one?
Yeah, so to my knowledge, most lighthouses are independently run. So for instance, the one that I connect with most frequently because I'm from Florida is the Tampa and St. Petersburg Lighthouse for the Blind. But I'm not even sure of the ones in Michigan. Sherry or Heidi, do you know of the ones in Michigan?
No, New York is one of them that we've worked with before too. Chicago, I believe, has one.
I think Chicago's our closest. I don't know of any in Michigan off the top of my head, um, but I'm from California, so there may be one and I
Mhm.
have no idea.
Great. Well, thank you so much. And just oh wait, I'm sorry, one more here. Okay. We do have somebody sharing a list of lighthouse locations. Before we close, let's try to get that shared to all of the attendees. Um, Daughter Liz, if you can just post that real quick. And then one final thing, our team is working hard on getting a survey out that is going to be focused on faculty and staff members who work at Michigan Medicine, want to learn about their experiences and try to make sure that the workplace is accessible. So we will be sharing that survey, and anybody interested in participating, if they have a disability themselves, would be really great if you can provide some feedback on that. So that would be posted in the chat if not already. It looks like it has. Okay, great. Okay, and we will keep everybody posted. Our next provider webinar series will be hosted in January. We'll have more information. If you are not signed up on our MDisability list, please feel free to share it, and we'll get you added so that way you can be notified about future events. Thank you, everybody.